My name is Steve Strobush. I'm the Senior Director of Market Development with Tenex Health. This morning, we're privileged to have Dr. Josh Hackle and Dr. Adam Porcho proctoring the session. A few housekeeping items before introductions and kicking off this event. Number one, as this is a Zoom session, we're at the mercy of the internet gods. So if there is a malfunction in the system, simply log back into the Zoom call with the link that you received from AMSSM. The session will start with a didactic session on Tenex led by Dr. Porcho. It will describe how the system works, clinical studies, etc. From there, we'll move on to the Cadaver Sessions. We'll have two specimens, one complete upper extremity, one complete lower. Demonstrations will be performed on each, alternating between the upper and lower extremity. Regarding questions, if your question is general in nature, feel free to add it to the chat window or hold it until the Q&A section at the end of the presentation. There will be an option for questions after the didactic lecture part of the conference as well. And then again, at the end, there will be general Q&A. So without further ado, let me introduce Dr. Josh Hackle and Dr. Adam Porcho. Josh Hackle, MD, is a board-certified and fellowship-trained sports medicine physician who specializes in treating musculoskeletal and orthopedic injuries. His primary aim is to maximize healing and minimize recovery time, allowing for rapid return to sport, work, and daily activities. His clinical interests include treatment of the musculoskeletal system, including ultrasound-guided, minimally invasive procedures such as bone marrow and adipose-derived stem cell injections, platelet-rich plasma therapies, Tenex, percutaneous tenotomy of the elbow, ankle, plantar fascia, knee, hip, and shoulder, and radiofrequency ablation for chronic pain and arthritis of the hip and knee. Dr. Hackle trained under the world-renowned orthopedic surgeon, Dr. James Andrews, during his fellowship at the American Sports Medicine Institute in Birmingham. Following his fellowship, Dr. Hackle was one of two physicians selected by Dr. Andrews to move to Gulf Breeze, Florida, and launched the Andrews Institute for Orthopedics and Sports Medicine. Dr. Hackle was the first physician at the Andrews Institute to utilize stem cell therapy successfully in the treatment of soft tissue injuries and joint disorders in an internationally recognized expert in stem cell therapies and ultrasound-guided procedures. He is a pioneer in diagnostic and therapeutic uses of musculoskeletal ultrasound in an orthopedic practice and developed one of the first musculoskeletal ultrasound continuing education courses in the country. Dr. Adam Porcho, DO, is a board-certified physician in physical med and rehab and sports medicine. He specializes in the treatment and prevention of sports and musculoskeletal-related injuries. His undergraduate education was completed at Michigan State University, where he received a Bachelor of Science in Kinesiology with specialization in athletic training. He graduated from medical school at Michigan State University, College of Osteopathic Medicine, did his residency in physical medicine and rehabilitation at Wayne State University, and did his fellowship training in sports medicine at the Mayo Clinic in Rochester, Minnesota. Over the last 18 years as an athletic trainer and doctor, he has worked with the Detroit Lions, Michigan State University, Wayne State University, Rochester Community Technical College, MHSAA Wrestling, AAU Wrestling, and athletes of all ages. He's been very active academically, teaching ultrasound to fellow physicians and in research with multiple publications on sport-related injuries, regenerative medicine, musculoskeletal ultrasound. He has also been active in the community as a head team physician for the Seattle Storm. Dr. Porcho has specialized training in diagnostic and interventional musculoskeletal ultrasound, which he uses to provide precise, minimally invasive treatments such as platelet-rich plasma, intra-articular, perineural, and peritendinous injections. He has specialized training from the Mayo Clinic in the treatment of tendinopathies with orthobiologics and ultrasonic tenotomy. Let's go ahead and turn it over to Dr. Porcho.
All right, sound working? You guys hear me? All right, great. Thanks for joining us for this session. Hopefully we'll answer some of the most common questions we get about this technology as far as my experience goes. This technology was coming about when I was a fellow at Mayo Clinic, so I got firsthand use of it starting with my fellowship. I've done roughly over 2,000 cases, and so we've made a few mistakes along the way, and we've also figured a few things out about tendons, how this works, especially the post-procedure protocols, and we'll talk a lot about that today. A little bit about me. He already introduced me, so I'll kind of skip over this. This is luckily a couple of years ago, I got to experience something that I've always wanted to do, which is walk into a room and spread champagne around and not only have people not be upset, but have them be happy about it. So one of my life goals was to be in a winning locker room after a championship. Got to experience that thanks to the Seattle Storm. Anyway, we'll skip through some of this. As far as disclosures, I currently have a grant from AMSSM to actually investigate ultrasonic tenotomy for the Achilles tendon. And this is an ongoing grant with several people, including University of Iowa, Mayo Clinic, among others. We also have a grant for regenerative medicine from Barbara Stephanis to investigate bone marrow and PRP and alpha-2 macroglobulins. So those are some of our upcoming research things. A few things, we'll just kind of briefly review. What is tendinopathy? What does that mean when somebody says you have tendinopathy? How is it treated traditionally? What is ultrasonic tenotomy? What's the science behind it? What tendons we can use this on? And then what's the evidence? And we have a couple ongoing IRBs, and we'll talk about some of that data here. So tendons, when we think about tendons, obviously it affects a large part of our population. There's probably nobody on this call that has not had a tendon issue at some point in their life, myself included. And I'll show you my images on here. And I've actually treated myself with the ultrasonic tenotomy, and I'll show my case on this during this presentation. So when we think about tendons, what we want to know about this is it's not an inflammatory problem. Really, the word tendinitis should be removed from our vernacular, in my opinion. I think the right way to think about tendon is tendon failure. So tendons, what happens is we get these micro tears in our tendon. Our body starts throwing in type 3 collagen instead of type 1 collagen. It's not as able to withstand a tensile load, and then the tendon continues to fail. So as we all know, anyone who treats a lot of tendons, I've treated about 30,000 now in my lifetime, I'm convinced that they don't heal on their own. And so when we get these micro tears, one of two things happens. We either get used to it and we live with it, or we get to this point where the tendon continues to rupture and we continue to pull strands of it out. As we know, when tendons tear, they usually don't tear like a piece of paper unless you have a big traumatic event. They usually tear like a string with multiple strands. And if you pull a couple of those strands out, you might not notice. You pull enough of them out, then it becomes painful. Usually I find that about 20% of the tendon proper will be torn before people hit my door. So there's this like threshold where once you cross that threshold, it's hard to get back up on the sword. So traditionally, cortisone injections can be offered as the next step in treatment for people who have failed traditional physical therapy and non-operative treatments. However, the recent evidence on steroids shows that, and this isn't even recent evidence, the first meta-analysis from 1977 showed that we started rupturing tendons when we put steroids around them, and that was Halpern et al. And so when we look at this, steroids may not be the best thing for our patients. We know they're toxic to tendon, they're toxic to joint, they're toxic to nerve, toxic to muscle, they cause lipoatrophy. So really, we should probably be getting away from injecting steroids into our patients. And so there might be a better way to treat these tendinopathies as opposed to this. And there's several things that we can talk about. So we'll concentrate mostly on ultrasonic tenotomy, but these other options of neovessel ablation with a tendon scraping, we can do a high volume injection. And then we're not going to talk about these today, but orthobiologics, these are just some of the other options in treating this. So when I think about tendons, I've been wanting to make this slide for years, so I'm glad I can finally do this. I like to think of it as a sausage on a grill. So if you have a sausage on your grill and you're heating it up and you don't want it to explode, you've got a couple options. One, we can turn off the gas. We call that a tendon scraping or high volume injection. So Alfredson Haken did the pioneer kind of piloting work on this. And this works very effectively, scraping those neovessels off if they're there. Two, we can poke a hole in it. That's your needle tenotomy. Three, if it has a peritoneum, you can do a peritoneum slit, try to remove the compartment pressure of the tendon. Or the last thing, ultrasonic tenotomy, we can scoop out some of the material in the inside. So those are our options to keep that sausage from trying to explode. And then at the top here, you'll see an example of severe tendinopathy of the mid-substance of the Achilles tendon with a partial rupture with extensive neovessel formation. So tendon scraping, I'm not going to belabor this. This is from a book chapter that should be coming out this year. This is your turning off the gas, right? This is using a meniscotome to scrape Kager's fat pad out of the Achilles tendon. Very effective. We use this in season. People can go back pretty quickly from this. However, it doesn't do anything to treat the pathology in the tendon for the most part, outside from just turning off the gas. This next slide is just an example of needle tenotomy. Sticking a needle in there, poking it around. That was our treatment for years until this newer technology came out for ultrasonic tenotomy. We could actually remove some stuff and agitate the tissues a little bit and actually create a healing response. And then we get on to the Tenex procedure. And this is just an example in the Achilles, right? Remove some of the meat. So and this is all done under local anesthesia. This can be done in a minimally invasive setting. It's done through a poke hole within the skin. As you can see, this patient's not writhing in pain. I don't do blocks on any of these patients. I know some people in the country do. You can make an argument for that. In my opinion, you're just asking for another problem. Anyone who injects a lot around nerves, sometimes you inject around a nerve and you get a horrible nerve pain afterwards. So I think you're just asking for another problem. Anyway, so this is all done in local anesthesia. This patient's comfortable. They're sitting on the table and we're just removing some of the meat. Okay, so ultrasonic tenotomy, how's it work? It's using the same technology that's been around for years to remove a cataract from an eyeball. Everything on earth has a refractory rate to sound. If I scream at the right pitch, glass is going to break. We can stick this into an eyeball and remove just the lens without sucking out the rest of the eye goo. And so when we think about tendons, the abnormal tissue, the type 3 collagen that builds up within the tendon has a different refractory rate to sound than normal tissue. So we can put this device in there, effectively remove the abnormal tissue with removing minimal of the normal tissue. So that's how this device works. And so what's the data on it? So let's, this is a great study on Achilles tendons in rabbits. And what we're looking at is they induce a tendinopathy in rabbits. We have them run around for 3 months. You treat them with the device, have them around for another 3 months, euthanize them, cut the tendons, look at the tendons. We're able to show that not only can it effectively target the abnormal tissue, but leave the normal tissue alone, but then have type 1 collagen and tenocytes go back within the tendon proper, which is what we want to see. 35 peer-reviewed publications. I have several of these. I'm not going to belabor this, but talk to you guys a little bit about it. Seems to be fairly effective in most of the tendons that we treat, above 85% certainly, and that's been our experience. And I'll show you our data that we're currently collecting right now. And then obviously the precise animal model showing that we're able to target this abnormal tissue. And all these studies are referenced at the end as well. So how does it work? So this is just an example in the elbow. Obviously, it works similar in the other ones. You numb the skin up first with local anesthesia, make a small nick in the skin. It's nothing that needs to be sutured. I usually just glue these shut or close them with a steri-strip. We guide the device down under ultrasound guidance. The device is going to agitate. It's going to show it moving here. It's pretty hard to see with your naked eye because it's moving so rapidly. Intraoperatively. It's going to flush fluid in and then debride the tissue based off that frequency in front of it and suck it out through a tube within a tube system. So this is our removing the meat out of the sausage. So this is from a study that we just submitted on the lateral elbow, and I'll share this data with you. This is what it looks like. This is our setup for the lateral elbow. This is what it looks like intraoperatively. You can see the device there with the arrow on the lower left-hand screen. And then this is a common extensor tendon example. This is a study from a couple of years ago that we published in 2018 showing that these patients had all had an open tenotomy with tenodesis and still had a lot of pain. And so the surgeon had asked me, can you go in here, use this device and try to debride this tendon a little bit more for me and see if these patients can get better? And the answer is yes, but this is a case series of 2 where these patients got better. I obviously was very careful not to tenotomize his suture anchor, which is marked on the top screen there, an A with the arrow. That's his suture anchor from where he tied the tendon back down to the epicondyle. And so I stayed away from that, but was able to effectively work around it with this device, treat these tendons, and still get a decent result in these patients. These patients both went back to work after 6 weeks. Here's another study I published with Derek Hall, 2015. This is, can this be used after a partial plantar fascia release? So this is a central band of the plantar fascia is cut. That's what's marked on the upper right image B. The preoperative x-rays are on A. You can see a little bit of calcium in there marked with the 2 arrowheads on the upper right. That was presumably the area of previous partial release. However, this patient has a lot of pathology just proximal to that, right where the PF is marked on the calcaneus there. This is still a thickened tendinopathic tissue. And so we were able to remove that tissue, and effectively this patient went back to work. Can you use it on hamstrings? Believe it or not, this is images from the first known hamstring case. As far as I know, I was the first one to tackle this in the hamstring. This is back when all we had was a TX1 device. I actually had to make a 3-centimeter incision, which I had to close with sutures because the device wasn't long enough to get down to the tendon. But now we have the TX2, which is a longer device and is able to reach this. So this is less of an issue, and I can actually treat a higher percentage of my patients. I remember when we first did this, we weren't sure what kind of protocol to put this patient on. She came into the office at 2 weeks after and was like, look at this, and, you know, put her palms on the floor, and both me and my fellow go, whoa, 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 whoa. And she ended up doing really well. So she said she had minimal pain after the procedure. Most of the patients, when we do this on the hamstring, and we'll talk a little bit more about this in a minute, takes about 6 weeks for them to start getting better. Here's an example in the supraspinatus. These are 2 different patients. On the left, you'll see a partial thickness supraspinatus tear coming off of the humerus area marked SS. On the bottom is 12 weeks after treatment. On the upper right, another partial thickness tear with a cortical defect. And on the bottom is 12 weeks after treatment. So you can see we were able to stimulate a healing response in this patient that effectively healed these tears. And both these patients did very, very well. So now we're going to look at the knee, patellar tendon. This is a preoperative MRI, as well as my preoperative extended view, field of view ultrasound, showing a partial thickness tear with moderate to severe tendinosis of the proximal patellar tendon. This is a guy that was still running ultra marathons at age 65. This is a nice example. You remember I told you about the sausage on the grill. So this one, we combined it with a tendon scraping. The nice part about this is half of his tendon is normal. Notice how the vessels stay to the abnormal half of tendon in the image on the lower right. So this is kind of feeds into that, you know, treatment possibilities for this is remove some of the meat, and then usually I'll combine this with the tendon scraping when I see this effect in the tendon. Basically leave myself nothing to come back for. Here's that same patient at 3 months. You can see that hole is filled in. The tendon looks better from an echo texture standpoint. He actually came back for his other knee at the 3-month point because he had similar findings. So can this work? I get this question a lot, is augmenting this with something like platelet-rich plasma. We have an ongoing investigation on this as well. So this is a patient, just to show you this can work on patients that have had this for a long time, because I can almost guarantee I'm going to get this question. Like I told you guys before, after 30,000 tendons, I'm convinced that tendons don't heal on their own. We either create these micro tears, get used to it, or we progress them at some point during time, and we continue to pull out fibers. So this patient had 4 years of plantar fascial pain. This is a high-grade, full thickness partial tear of the central band. You can see on the top left image there marked with the arrows of the plantar fascia. So what we did is we used ultrasonic tenotomy to debride this, get it back to clean margins, and then I injected it with platelet-rich plasma. And so the middle image is 6 weeks after treatment, and the bottom image is 12 weeks after treatment. This patient went back to full running by 3 months. So anyway, this is my elbow. This is from a couple years ago. I had a 90% tear in my common extensor tendon. I thought for sure I was going to have surgery. In fact, I had a surgery lined up for 8 weeks after I was going to treat it myself. I had my fellow hold the transducer and treated my own with ultrasonic tenotomy, followed by platelet-rich plasma. So I had about 9 months of pain, but really 9 years. I know when I did it, I hit an errant golf shot and hit it fat and felt my tendon go about 9 years prior. I was in a lot of pain for several months, got used to it. Had several times over the years where my pain had flared up, probably pulling out more of my fibers. I knew I had a tear in there, but this one was caused by my dog ultimately. He pulled one way, I pulled the other, felt a pop, thought, oh boy, there it went. Got to the point where I couldn't hardly, shake hands or grip anything. And so at the top is my initial image, and the middle one is 6 weeks after treatment, and the bottom one is 12 weeks after treatment. Now, my experience was way worse for the first 2 weeks. And then it kind of went back to where it was at. And then it kind of did a funny thing where I had pain-free days intermixed with days where it really hurt. It did this up and down thing till about 6 weeks. I was about 60% better from a pain standpoint at 6 weeks. By 8 weeks, it was like somebody flipped a switch. I thought, boy, I'm just having a good day, and I haven't had pain since. And so anyway, I love throwing that up there just to show you. It's kind of like the hair club for men. I'm not only a spokesperson, I'm also a client. Anyway, so just to show you guys how you can remove bone with this device. This is a patient with a large symptomatic enthesophyte. A lot of times I leave these enthesophytes alone unless I think they're symptomatic. You know, if they're in the shoulder, usually they're going to be symptomatic, and it's going to be calcium hydroxyapatite. This one's a solid one. You can see it's casting a shadow. So it's been there for a while, but he's getting a lot of pressure on the back of his heel with running. And then he's also got that partial tear where the arrow's at on the upper right. Greater than 10 years of pain, insertional Achilles tendinopathy with a Hagelin's deformity, and enthesopathy. And so we treated this with ultrasonic tenotomy. I also injected platelets in this, and I also did a tendon scraping on this because he had a ton of neovessels, which I'm not showing in any of these images here. He was pain-free in about 4.5 months. It took a little bit longer for him to get to pain-free, but incrementally better. He went back to full tennis by 5 months. But you can see on the follow-up imaging, the enthesophyte's gone and the tendon ecotexture is significantly improved. These tendons almost never return to a normal size. So if you're looking for that and the patient's expecting that, I think it's good to preface it with they never look normal once you damage them, and they almost never go back to looking normal after any procedure. But as long as their pain's better, who cares what the tendon looks like? So here's our data. This is 80 patients we followed out to a year on the lateral elbow. This is the one we just submitted. Things to point out there, the DASH score initially of 40, I'm sorry, my eyes aren't the greatest right now, and they have this at an angle, but 49.8 is, I think that's what it says. It went down to about 4.9 by a year. And then the VAS of around 6.7 down to 0.57 by a year. And as far as the changes on ultrasound, you'll see those at the bottom there. You can see the changes in hyperechogenicity, hypoechogenicity, and then also the satisfaction rate was 94%. So the majority of patients got enough improvement that they were satisfied with this procedure and would recommend it to a friend. It's minimally invasive. The downtime is pretty minimal. Here's another demonstration of that data over time. The biggest thing is notice by 2 weeks, they're really not better. You see that line there on the dash? So you need to tell people that like there's nothing magical about this device. It's a debridement tool. Right? So is it less invasive than cutting somebody open? Absolutely. But you're still removing tissue and you still have to let that tissue heal. I tell people, most people really start turning the corner from 6 to 12 weeks. So I preface that when I try to, talk to patients about this, they're like, well, how long am I going to, the first question you're always going to get, well, what's the recovery? How long am I going to be out? I tell them really just range of motion for the first 2 weeks, regardless of what tendon I'm treating. And if it's a lower extremity, I'm going to put them in a boot for the first 2 weeks and let that tendon calm down and let the body go through its healing process. The right way I think of this is it's a controlled burn. And so oftentimes these tendon tears, especially if they've been around for years, I don't know when they happen. But I know when, after I treat them with the Tenex, I know when that injury happened because I just created it. And now I'm going to control the rehab afterwards and get them back to where they need to be. This is from our publication. Again, more images on the top left there. You'll see the partial tear. The middle image on this patient is 6 weeks, and the bottom image is 12 weeks. So this one remodeled by 12 weeks, and they don't all remodel by 12 weeks. And here's an example of that. This is one of our patients that lingered a little bit. And so initial image on the top, on the left of the screen, and then the middle image is at 12 weeks, which it hadn't fully remodeled. And then by a year, it had fully remodeled. So my best advice is don't freak out if these patients aren't better at that 3 month point. I used to think, God, 3 months is probably what we're going to get. But I was really surprised when people coming in at a year and we're getting these surveys back and seeing that people continue to prove up to a year, which makes total sense if you follow Wolf and Dennis's law of tissue remodeling. So here's that same data again. This is our 80 patients. And this is the other thing I want to talk to you about is the average energy time. I've heard some crazy stories of people doing 20, 30 minutes of that. Let me move this way so you can see that. There we go. There you go. Now you can see it all. Anyway, sorry, we're learning with this technology here. The average energy time for us out of all these patients, 152.2 seconds. So it's not a lot of time. I'm not in there for like 20 minutes grinding away at this thing because there's got to be a point where you can do too much, right? And I don't want to rupture a tendon. I just want to debride it, stimulate that healing response. You don't need a ton of time. Average age is 51. Average length of symptoms 29 months. This is a DASH score, so you can see closer to 0 is going to be less symptomatic. Notice by 2 weeks, really about the same, maybe a little bit worse. That was my experience as well. From 2 weeks to 6 weeks, you see that 50% improvement. From 6 weeks to 12 weeks, you see another huge jump. But most people still had some pain at that 12-week appointment. You know, 1.5 out of 10, it's livable. I consider anything less than 3 over the age of 40 to be livable at this point in my life. If we could take, so I tell patients, if I could take you from a 6.7 down to a 1.5 by 3 months, down to a 0.6 by a year, you'd be pretty happy. So we had no recurrences, we had no open surgical conversions, we had no major complications, no infections. 8% of patients were recalcitrant to treatment. So it's just like anything. If anyone tells you something works 100% of the time, you should run out of the room, in my opinion. There are certainly patients that don't get better with this. And then you have other options, as you know, I discussed earlier, to try to get them better. Certainly it has a high success rate. So that's very satisfying as a physician. It's also satisfying for patients. This is from our open IRB. I'm just going to show you some preliminary unpublished data on this. This is plantar fasciopathy. So far it's 88 patients. We're still waiting for a few of them to get out to a year. 7 were lost to follow-up. Again, notice our average treatment time, 156.8 seconds. We're right around that 2 to 3 minute. If you're removing bone, that number is going to go way up. That's your energy time or your cutting time. Average length of symptoms, again, you could see all these numbers. This is going to be on a FAM score, which normal is 82. So you can see those numbers kind of improve. Interesting about the plantar fascia is oftentimes people will tell me at 2 weeks it's already feeling better. So again, different tendon, maybe different results. Usually I put these people in a boot for a couple of weeks, and I have protocols on all of these, and I'll leave my email up so you guys can read that. We did have one patient that had a recurrence of this, and it actually, I think it's my fault. I didn't treat far enough distally. Going back and auditing myself on this, and I probably needed a little bit more energy time, and I needed to treat it distally. So I think I didn't quite get it. And so we actually repeated the ultrasonic tenotomy. We had no open surgical conversions. Again, 9% recalcitrant to treatment. So these numbers are pretty consistent across the board with different tendons. So now we'll talk about hamstring. I'm really looking forward to publishing this data because this is probably the largest group of hamstring patients that have been at least tracked treating this. Notice my energy time is a little bit higher, right? So typically I find, know what you're treating here. Oftentimes these patients have conjoint tendon, ischial head of the adductor magnus, and then your semimembranosus. All three are usually involved with these patients. So you need to make sure that you pick an angle that you can get to all three of these. And usually I treat these lateral recumbent and move the sciatic nerve out of the way. I come from over the top of the patient and dunk the device in there. And so very well tolerated by patients. Now that there's a longer device, you can actually get down to these tendons. Before I used to have to like cut the skin open and bury the device in the fat in the skin and then close that up, which wasn't a big deal, but left a bigger scar. Anyways, the results kind of similar. They kind of speak for themselves here. Achilles tendon, again, 70 patients. Energy time's a little bit higher on this. And I think the reason why is it's usually a larger area in the Achilles tendon that's affected. This works more effectively on mid-substance than insertional, which is true with any type of treatment on the Achilles, in my opinion. The insertional ones are always harder to treat. I think they're just a different animal. So we had 12 recalcitrant, wasn't as effective in the Achilles as it was in other tendons. We had to repeat a tendon scraping in 10 of them to try to get those neovessels off of there. And I had 2 of these that we repeated an ultrasonic tenotomy. And again, I think this is my learning curve on this, was I didn't treat far enough north on the tendons. So no open surgical conversions. So patellar tendon, very similar results. The patellar tendon is also a different beast. You have to offload these people, especially the first 2 weeks. So you're putting these people on crutches. The patellar tendon, you got to treat it differently than other tendons. And so we need to make sure that we're aware of that. And these, again, oftentimes combined with a tendon scraping. So again, summary of this, ultrasonic tenotomy is safe. Thousands of patients have got it, has a minimal complication rate to our reported data. The peer-reviewed literature supported that's good to excellent outcomes. Our current data collection is good to excellent outcomes have been treated with this. We have 2 ongoing IRBs, one of which is funded by AMSSM to look at this technology. And so hopefully that was helpful for everyone. I know I didn't cover every tendon. I didn't cover gluteal tendons, and you can ask about some of these. I think I always get this question as well, as far as like peroneal tendons. I think the tendons are too small. I have treated a couple of peroneal tendons. I think the tendons are too small for the device, not as effective on some of those smaller tendons. So I think you gotta be careful picking your poison on what you're treating. If anyone has any questions, feel free to email me anytime. I have protocols on all of these. We update our protocols every couple of years. Anyway, that's all I got for you guys. So hopefully everyone's surviving their pandemic, and hopefully we can do this live next year and actually see all our friends again.
So are there any questions out there right now?
Are there any questions from folks viewing online?
Is there anyone typing anything in, guys?
Please feel free to type in any questions in your chat box, and we'll try our best to answer all of them. My name. Hello, I'm Josh Hackle. Thank you for attending this virtual course. I want to thank Trice Medical and Tenex for the privilege of us coming out to speak to you today about the ultrasonic percutaneous tenotomy device, Tenex. First, let's talk about the console here. If you want to show a picture of the console for us, you can see it's very nicely laid out. We typically will turn on everything: irrigation, aspiration, cutting power between medium and high. Maybe when you're starting out, start out with medium, but as you get accustomed to the device, you can switch to a high cutting power. So we'll move on to the elbow, our first area that we'll demonstrate for you. You can see whenever you're doing ultrasound, it's important to identify the important anatomy, things that you can potentially cause harm. And in this instance, we've got the medial elbow. Now, for the medial elbow, I'll have the patient in the supine position with their arm abducted 90 degrees and externally rotated, exposing their medial elbow. Before I get started, I do a survey of the anatomy with my ultrasound. The main thing to avoid on the medial elbow is the ulnar nerve. So we want to identify, you can see the circular structure, the ulnar nerve in the ulnar groove where it's appropriately supposed to be. You certainly want to make sure it's not subluxed or subluxed over the medial epicondyle, because you can certainly damage the nerve. Next, we identify our anatomy on the medial elbow. You can see there the common flexor tendon and the medial epicondyle. There's the joint in the middle of the screen. And so once we've looked around, we'll then use our lidocaine to numb up the area. We'll come in with the lidocaine, and I start superficially and work my way down to the hypoechoic defect. Typically, it's a hypoechoic defect. It can be irregular. It can have some neovascularity. I'll turn the Doppler mode on to identify the hyper or the neovascularity sometimes, and I'll even use that as part of my target area. So once I'm happy with the lidocaine, I'll also fenestrate the area with a 14 gauge angiocath, or if you don't have that, you can use like an 18 gauge needle or even a 22 gauge. So then we introduce, this is the TX2 device. It's a longer tip. When we first started, we used the TX1, but I use TX2 for most areas except for when I'm trying to remove bone. So we'll introduce the tip down to the enthesis, or the origin of the tendon, and there's a foot pedal that you can't see, but that foot pedal will initiate the energy, the to and fro of the tip. You'll hear it sounds like you're at the dentist's office getting drilled, and you go back and forth with the device to ablate that tendon tissue. Sometimes you'll hear the device stopping the flow. You'll hear three beeps. And so what I do is I take my foot off the pedal and I'll realign. I'll see where I am. You're constantly stopping and starting when you're doing this procedure, trying to get the tip in plane with your transducer so that you can see it well. And then again, you'll start again, back and forth, trying to remove the degenerative hypoechoic tendon. And so after a couple, or it depends on the size of the tendon, it's also a feel thing. You'll also feel it may start with some resistance as you're going back and forth. And then as you get going, the resistance reduces, the hypoechoic area becomes hyperechoic, and usually between 1 and 2 minutes for the common flexor tendon, you're done. So that's about it on the medial elbow. We'll now transfer over to Dr. Porcho to look at the knee.
All right, you guys got it going? Yeah, there you go. There we go. A little bit more. A little bit more. I'm gonna move that in there. Perfect. Okay. All right. So yeah, slide it to the. There you go. A little bit more. A little bit more. Okay. Perfect. All right. So middle knee. Usually I will come in order to board the genicular nerves. Come lateral to medial on these. I'll usually have the knee over a bump, like I have this cadaver here. And so we'll take a look first, and usually it's that proximal pull of the patella that gets affected. I'm going to turn short axis on it. I'm going to come underneath. Typically it's a central third, so I don't want to go through normal tissue if I don't have to. So I'll come up through Hoffa's fat pad and come up into the tendon. And so again, just like Dr. Hackle, I'll numb it first. You'll see my needle come from the right of the screen there, and I'll peel this fat pad off so we can inject fluid. Peel this off. You can also, while you're here, do a tendon scraping and scrape this off. You can use a meniscotome or even an 18-gauge needle. It's a lot easier to do it with meniscotome, or you can use the Tenex device itself to scrape it. I do that sometimes as well. And so I'm going to come up from underneath the tendon here, from left to right, and I would numb it, up into the central third here. And then once I was good and numb, I'd come back out. We're going to use our scalpel or our 11 blade, so I can get the top off without cutting my hand. 1 second. There we go. Okay. Back to work. Making a little cut with the 11 blade. And typically, as part of the tenotomy course, we can talk about this as far as the billing goes. You want to, there's a little button on the side of this thing. Keep cutting. There we go. Okay. I take a picture of my blade in there just to show that I'm cutting the tendon. It has to do with that AMA statement from a couple of years ago. So I'll take a picture of the blade. You can see my blade on the left of the screen there. Make sure I bury it all the way down to the hub on this. That gets enough room for the device. And then I have this set on medium, so here it's going to make a different noise here than the other machine. Sounds like a Sonicare tooth cleaner to me. Usually come from, again, lateral to medial. I'm going to come up through the fat pad. Now, as you come in, if you get tissue resistance, it's a cutting device. Just turn it on a little bit and it'll pop in just like that. And so now we're going to see the device from left to right here. I'm going to confirm that I'm in the right spot. So I'm going to switch to a short axis view. And, similar to what Dr. Hackle was saying, you're going to switch from short axis, long axis view, constantly confirming you're in the right location and treating the right spot. Then we turn the device on, I come up into the tendon. You can see it kind of pops into the tendon. Notice how I'm anchoring myself with my hand. I got my pinky down on the skin here because sometimes it can be quite hard to get into these, especially a quadriceps tendon. You want to make sure you're in the right spot, and then I'll work through the tendon like a grid. If you do a little oscillation with it like this, it tends not to clog as much. Again, those beeps, it does 3 of those beeps in a row, and the device will turn off, and I'll just demonstrate that now. So the device is no longer cutting, but it's beeping at me. So if you let up on the gas, it clears the tip. There's less likely to get the tip. So I'll work through the tendon like a grid, again, switching from long to short axis. And once Once I usually start proximal, distal, distal, proximal. Once I get to the area of hypoechogenicity, I'm done. And then, 2, 3, sometimes up to 4 minutes in the patellar tendon, depending on if there's calcifications. All right, so we'll switch back over to Josh here and have him do another.
Okay, thank you, Dr. Porcho. So now we've got the lateral elbow exposed. The patient, again, is in the supine position with the arm abducted 90 degrees. So again, I'll look at my anatomy with my ultrasound. I'll even, before I get started, I'll palpate the lateral upper condyle, and I ask them, where is their pain? And so then I want to see it with the ultrasound. How does that correspond, where I make a little dot where the maximal point of tenderness is? And then that'll help me identify the area, and I'll focus on that area possibly more than somewhere else that's completely not near where they are hurting. So again, we want to look at the anatomy. We identify where our target is. If you're using the TX1, I put the defect or target in the middle of the screen. The key when starting this, and I think this is very important, is put the transducer such that the target is in the middle of the screen. That tells you where to make your cut. Now, before I make the cut, again, I'll use my lidocaine, and I'll use the needle to make sure that the needle is not too far away from my target. So once I've done the anesthetization or anesthetize the area, then I'll use the scalpel to make the incision where I penetrate the skin with the needle. So once I've got my 3 millimeter poke hole incision made, I'll go down through to the tendon, and I'll look at the scalpel going into the tendon. I'll then take the scalpel out, and I'll introduce the device. And you can see here, the device goes down. That's the ski slope appearance of the common extensor tendon, the lateral upper condyle there. Again, as Dr. Porcho mentioned, we'll do bursts of energy with a to and fro motion. And you can see it's more of a constant sound with the high energy versus the intermittent sound that you hear with the medium energy. So I'll go long. We're looking at the device in long axis. We're going back and forth, trying to ablate the defect in the common extensor tendon. Typically at if the lateral upper condyle, if you look at it from the top to the bottom, the top 60% of that lateral upper condyle is the common extensor tendon. The bottom 40% is the radial collateral ligament. So I'll also make sure I'll document what the radial collateral ligament looks like prior to beginning. I'll document whether it's damaged or not, and I'll comment on that in my notes. So we're focusing on the top 60% of the lateral epicondyle, or wherever the defect is within that top 60%. We'll go back and forth in long axis, and then I'll shift to short axis to make sure, like Dr. Porcho said, in a grid fashion so that I cover the entire area of defect. Once I feel like the resistance reduces and the area that in question is changing color, and I feel like I've ablated enough of the tissue, I'm done. So that's the lateral elbow. Let's switch back to Dr. Porcho.
You got to get on the Achilles. We're down there. There you go. There you go. Plantar fascia. There you go. Now we got it. Okay. So we're looking at the plantar fascia here. Typically, I'd have the patient lateral recumbent with the affected side down, pillow between the knees, and the other leg moved out of the way. This is a very comfortable position for the patient. It's comfortable for me. And in an ideal world, I would have the body completely on the table, so I can rest this hand on the table for anchoring. And so we're looking at the central and lateral bands of the plantar fascia. Obviously, central bands more commonly affected. Typically, I will do this from a medial to lateral direction because they already have pain walking on the medial side anyway. So rather than adding another reason for them to not walk on it. So so coming from lateral to medial, I'll get my best view of the tendon here. Usually it's about a centimeter down. I would numb it first. You're gonna see the needle come from left to right. Hopefully you guys can see. I'm trying to keep my elbow out of the way here. And to come down into that plantar fascia there. We numb it up on the way down. I usually peel the fat pad off a little bit here, which will help. See that fat pad peel off? There we go, in the image there. So peel that fat pad off. A lot of the neurovascular or nerve supply comes through the fat pad. So if you can numb this up here and just wait a couple seconds, they won't feel you go into the tendon. Then I'll back up and numb in the tendon. You see me numbing. I'll show you the device here. Then we're going to come out that way, and we're going to take our scalpel, come back down the same poke. I'm going to lift normally I wouldn't have my elbow up like this, but I want you guys to see from the camera angle. So I bury that thing in there, get a picture of that in there as well. And then we'll guide the device down here. I'll just leave it on medium because Josh is doing the high stuff, I guess. Normally I wouldn't hold my arm up like this, but I want you guys to be able to see this. Hold on, let me whoosh this around the other way. There we go. And so I like using the TX2 again, just like Josh was saying there. You're gonna feel it pop into the fascia. There's always a little bit of resistance to it, so you got to be ready for that to not poke through the other side. And then we can treat this, like a grid, similar to how we treat the other way. Turning from short to long axis. There's my needle tip there, and I can move it to different sections of the fascia. Turning from, again, these orthogonal long and short axis views of the device, and treat my way through the tendon like a grid. Again, average treatment time, like I said, in our study is like 156.8 seconds. So, and I think Dr. Hackle made a great point of oftentimes in that common extensor tendon, it does involve the radiocollateral ligament. And so make sure that you note that ahead of time. So it's not, hey, you did damage to my radiocollateral ligament. So just got to be careful with that. There's another great talk on there on if you look, I did a talk for AMSSM a couple months ago on the lateral elbow, and you can look that up, and talks a little bit about some of that anatomy that he's talking about. All right, that's how we do the plantar fascia.
Thank you, Adam. So now we've got the shoulder in view. So what we can either have the patient in a beach chair position or lateral decubitus, whatever you feel more comfortable with. Again, we're going to do a survey of the area, looking at all the anatomy. Typically, we'll use a TX bone for this, because there you'll see a calcification that'll show a hyperechoic calcification with some shadowing possibly. If it's not very solid material, if it's not really hard, it may not cast much of a shadow. Usually when I'm seeing this patient in the office, I will have tried an injection. And what I like to do first, I'll start with a subacromial subdeltoid bursa injection. I'll start them in physical therapy. If they come back with pain, then I'll look again, and I might stick a needle into the calcification to see how hard it is. If you're doing a rotator cuff barbotage, you're not going to have much success if that material is solid, really hard. So I might do a barbotage if it's soft. If it's hard though, it makes no sense really to do a barbotage. So then I'll go to the Tenex bone device. So here we are with the patient on lateral decubitus for demonstration purposes here. I'll identify the tendon. I'll then, again, make my incision corresponding to where I want the device to enter. I'll start with, my lidocaine. I'll numb up, I'll go down and I'll numb inside intratendinously with lidocaine. I'll even poke holes in it, the calcification if I can. And then I'll bring in the device similar to as if I was doing an injection to the bursa. Say I was injecting to the bursa right there, but I'll introduce it further. Then I'll depress the pedal. The device goes down to the area in question. In this case, this patient does not have a calcification, but you can imagine in your mind's eye a calcification or something right here. You're going back and forth with the tip, removing the bony substance, the calcium hydroxyapatite, as Adam mentioned. And after a few minutes, when you're doing bone work, it takes longer. Again, you're going to have the TX bones a little shorter than the TX2 that I'm demonstrating with right here. So you're going to have to make your incision potentially a little closer if you're using TX bone down closer to your target area versus TX2. You can make the incision farther away. So let's see. I think that's about it regarding the rotator cuff.
All right. So we lucked out on this one. We have some pathology on this insertional Achilles here. There is a partial tear here as well as an enthesophyte you can see here. So this patient, I should say, this body has potentially some history of Achilles pain. So you can see that partial tear with that little enthesophyte there up on the ultrasound there. So what I'm going to do is I would usually come medial to lateral for the reason of there's a couple things you got to worry about here. You've got the lateral calcaneal nerve on the outside off the sural nerve when you're this low. And then of course you've got the sural nerve higher up here that you don't want to hit. That's it coming off of from moving from right to left on the screen over the top of the Achilles. And then on the inside, you've got your medial calcaneal nerve to worry about, which this cadaver is a little bit frozen. So I don't know if I'm going to get you the best view of it. That looks like it coming up right there. So just be aware that those structures are there. It's easier to come medial. The tibial nerve tends to be more out of the way, but obviously knowing your at-risk structures before you do any procedure, kind of the key. So we'll turn to, I'm going to go again between long and short axis views. I'll come from medial to lateral, see if we can remove a little bit of this bone for you today. We guide about half a centimeter down. So I would numb it first. I would peel off the bursa first. That usually gives people a lot of the nerves are up in the bursa. So just be careful you don't poke your finger because you can't come right through the skin. So we'll see if it'll let me peel this off. It might not. It's pretty frozen. No, there it goes. So I'm going to do a high volume injection, peel that bursa off. You can see that coming off the top there. And then I would come back down, let that numb up for a minute, and then come down actually into the tendon. And like Dr. Hackle's saying, I tend to poke holes in it. I tend to use the needle to check how hard the enthesophyte is, but we'll come after this one down here. Let's angle right at it and see how hard this thing is. It looks pretty solidly formed. So we'll come right across here. There we go. No, actually let me go right into it. So it's actually, this will probably suck out pretty easily. That one's pretty solid. Anyway, so once we've numbed it up, we'll grab our scalpel. And as Dr. Hackle was saying too, you can use the length of your needle. So if you're using like a 2-inch device, use a 2-inch needle, and that'll tell you how far you can get, right? You want to make sure you can get down to the treatment area. So with this, I would angle it right at that enthesophyte and bring the device down here. And I'm actually going to change my setting to high so I can actually see if I can rip that bone out of there for you guys. Okay. All right, get on my pedal here. So come into the device here. You can see it has a little resistance as it comes in, and then we can angle it right down to that calcium there. So I find when you're removing calcium too, this is another great tip, is get on the edge of the calcium and let it soften first before you go into it. So I'll sit on the edge of this for until I see it and feel it soften on the ultrasound. So you don't want to just try to jam it right in there, because you can actually break the tip of these and so you got to be patient with the calcium. And the other thing too is with this device, it can heat up, and you don't want to create a thermal injury. So make sure you're letting up on that pedal more and more, especially when you're removing bone. I have had a couple, thermal injuries at the skin just from keeping on the pedal too much. You're like, oh, I just want to get the job done, but you got to let this thing cool off. And switching it back to medium, well, it doesn't tend to heat up as much on medium. So just be careful with that when you're doing it. So you can see this is slowly pulling that calcium out of there. Here it goes. It's starting to come out now. So you just get this feel for it. I'm just kind of working the edges of that calcium there. And you can see now the device is able to go further and further in. There it goes. It's sucking out now. So we're seeing that calcium, being pulled out of there just slowly over time. I got another little nugget of it here. So, I've belabored this, but just, a big thing with the calcium is get right on the edge of it like I just did. Let it soften and then suck it out before you try to just jam the device into it, and as Dr. Hackle was saying, is test how hard it is with the needle first. If it's a solid nugget, it's not going to suck out super quick. If you can shove the needle through it pretty easily, those ones tend to whoosh right out of there. So just be aware of that. And then down here as well, as far as the sausage on the grill phenomenon that we talked about in the lecture, is I will often combine Achilles almost always with a tendon scraping, either of the bursa superficially or especially mid substance underneath through Kager's fat pad. All right, so I think that's, you got another one? Oh, we have triceps. Okay, we're gonna head back.
Okay, good. So thank you. Now moving on to the triceps. One important teaching tip is make sure the patient's comfortable. And for the triceps, I put the patient in the prone position. I have their arm kind of hanging off the side of the bed, and then I'm distal to the arm, kind of sitting in next to their torso. One important other thing is obviously make the patient comfortable, but you got to be comfortable too. If you're doing this day in and day out, you want to be comfortable, you want to be seated, in a good posture position. Also, you want to make sure that your ultrasound device is directly in front of your line of vision. So when you have your transducer down, you want to be looking, you only want to move your eyeballs. You don't want to turn your head to look at the ultrasound device, because when you're looking at the machine and not at your anatomy and your peripheral vision, you're moving and you don't realize it. So it makes your day a little more difficult. So again, we'll put the transducer down. You can see the hyperechoic tendon fibers attaching to the olecranon tip here. I'll start with my lidocaine. I'll inject down to the superficially and then into the tendon itself. Then I'll make my skin incision, which I've already done for you here. I'll introduce the device down to the tendon defect. And like Dr. Porcho was mentioning, it sometimes can be difficult to get down there. So don't force it. Don't force it. You just turn the device on to kind of penetrate that outer fascial layer, and then you'll go back and forth to and fro to remove the spur or the hypoechoic tendon defect from within the tendon. And that's how we do the triceps tendon.
Okay, thank you, Drs. Porcho and Dr. Hackle. We have a bunch of questions that have come in, so let me go ahead and start at the top and just start bringing them down. So the first one is, what are your preferred console settings for the studies that you're doing?
Are you talking the I'm assuming they mean the console, the actual Tenex console. If I'm removing bone, I always put it on high aspiration for a couple reasons, and I'll go over those. And then if I'm removing bone, I'm going to put it on the high cutting. If I'm removing tendon, I usually leave it on medium. Sometimes though, if it's like a real tough tendon, like a quadriceps, I'll leave it on high for a good portion of it. And then sometimes you switch back and forth. Let's say you have tendon and then you have a little adhesophyte you're moving, I'll switch back and forth on it. I think that's the way I use it anyway. And again, just be careful about your energy time. When it's on high, the device will heat up, which it can be, you have to let up on the gas pedal, don't burn the skin. The other thing with the high aspiration is, especially when you're treating an elbow, a lot of the fluid that's being flushed in can't be sucked out fast enough. So some of it gets trapped under the skin. I spend 4 or 5 minutes squeezing as much of that extra fluid out of there, because if you just close the skin, you just increase the compartment pressure in that area. And so you want to be careful with that. And so you want to get as much of that fluid out of there as you can. The patient will be more comfortable that first 24 hours. So that's one of the other things I've noticed with it.
And I tell the patient when there's that fluid buildup there and you can't get it out, you just tell the patient it will resorb back into the body. This is normal. Do not get, don't be upset about it. This will resorb and it'll flatten out. So I agree with everything he said as far as the settings are concerned.
Okay, the next question is, do you restrict the anti-inflammatories at all?
I do. I'm not a huge fan. As somebody who does a lot of regenerative therapies, and I think, I know it's not the topic of this one. I think Josh is probably on the same board with me, is that I'm not a huge fan of anti-inflammatories to begin with, just because we know how they deactivate your platelets. So we're turning off a healing process anyway. So my answer is yes. I think this is just theoretical based off tissue healing. Oftentimes I will have patients want to combine these procedures, as I showed in my demonstration, myself included. I combined mine with platelets. Basically dig a hole. The concept makes the most sense to me. Dig a hole and then put it in the best environment to heal afterwards, right? And so by putting a bunch of your healing particles in there and growth factors, you're just taking advantage of that controlled burn. But I tend to restrict them about a week before and 2 weeks after. I'll usually give them about 3 days worth of pain medications, especially for an elbow or shoulder. But a lot of patients tell me they take like 1 or 2 pills first night and then they're fine.
I agree. I let them or recommend anti-inflammatories in the acute situation, but when you're talking about a chronic tendinopathy, to inhibit the body's inflammatory cascade process makes no sense. So I withhold them as well.
Okay, very good. The next question is, are you worried about using antibiotics during the procedure when you intend to take off bone?
I don't use antibiotics at all. So I don't know. I have, knock on wood, not had any infections related to this procedure. And so I think if you're doing a good, sterile, prep, I do a double chloroprep. I chloroprepped it. I put down my sterile towels. I do another chloroprep. I'm wearing sterile gloves. I have a transducer cover. You're doing, sterile gel. You're doing everything sterilely, sterile drop of your medications, your numbing meds. So as far as I assume this question is coming from the whole fluoroquinolone thing. That's probably it, huh? Yeah. So I think, I don't know, I'm not one who gives out a lot of antibiotics anyway. So I think if the answer is, should somebody be off antibiotics, that might be the other question you have here, based off how kind of open-ended that was. I don't think it's an issue with it. I'm not a huge fan of fluoroquinolones in general. And in fact, I never would use those on an athlete.
Or anyone.
Yeah, exactly. Because I've seen so many of those, as I'm sure people in the nation have fluoroquinolone-induced tendinopathies, and they're really hard to treat, and it affects a lot of the tendons in the body. But I don't use antibiotics. Do you?
Okay, the next question is interesting. How do we get started on this if you didn't have ultrasound training and fellowship?
Well, that's a good question too. one, get out to courses, like AMSSM, attend the advanced courses, attend the beginner course. They have a beginner and an advanced course, which I teach out of both of those. And I'm sure Dr. Hackle teaches those from time to time as well. Is that, it takes time. It's just like anything else on the planet. Do something for 10,000 hours and you'll get better at it. You have to first know the anatomy, right? So you've had some of that training, preferably if you're in sports medicine, you've had some of that training and you had some in medical school. You have to know the anatomy cold, know where you're going to get into trouble, know what nerves are in the area, know where you're going to get too close to the sun and be able to back away. And so I think that's my advice, is know the anatomy cold first, and then just practice, and then practice some more. So
a little shameless promotion. The AIUM and the Andrews Institute co-sponsor an ultrasound course every year. I agree. You got to go to courses, not just one. It's a steep learning curve. There are several books to buy that are very good at showing the anatomy and the pathology. When I first started in fellowship, we didn't have ultrasound. So if you're not being taught in fellowship now, that's just the same as me. So when I got out into training and then ultrasound came along, I fortunately adopted it into my practice. And what it does is, sure, you can know the anatomy, but the ultrasound is really going to let you learn the anatomy even better. So you'll become an expert anatomist. And so the ultrasound is wonderful at teaching anatomy, and that's why many medical schools now use ultrasound to learn anatomy. Once I became proficient with the ultrasound, then these different techniques of treating things came along, and with the assistance of ultrasound, these techniques made a lot of sense. So it all fit together. But the key point is, buy some books on ultrasound, go to courses. I learn every time I go to a course, I learn something from my colleagues. You got people like Dr. Porcho, who are some of the best in the world teaching. You'll always learn a lot going to the courses every year.
Yeah, I think it's constant learning. You just have to really, really know the anatomy and look at a lot of normal before you call out abnormal. I'm doing things now that when I first got into practice, I wouldn't dream of been doing, like carpal tunnels and trigger finger releases, bicep tendon releases. These type of advanced procedures, you have to really know your anatomy and then have a good group of people around you, because if you get into trouble, what's your backup? So make sure you have a good relationship with your orthopedic colleagues and they're comfortable with what you're doing, and you have to demonstrate that you really know stuff before you're going to go down these avenues. But I agree, it's a learning curve, going to great courses, learning from great instructors, asking a lot of questions. Initially, when I first got out, I ordered a lot of MRIs to confirm what I was seeing on ultrasound. And now I've got to the point where I'm so comfortable with what I'm seeing on ultrasound, I don't order the extra imaging. And a lot of the referrals, the orthopedists will refer for, hey, is this a tear? Where's the nerve cut? And they trust my imaging to the point where, they don't have to have any additional imaging. So I think a lot of that's experience, and a lot of that's just, to think of it as the sports doc stethoscope. It's great when somebody says, yeah, it hurts here, but you go, hey, what's there? Slap a probe on there and see what's underneath there. And you may find that, man, I was wrong. It's not this. And then you learn from those experiences. And it actually has really improved my physical exam as well.
So if you're not being trained in fellowship, you're coming out and you're trying to adopt ultrasound in your practice, usually you'll have an MRI on the patient. Before you start billing for diagnostic scans, I look at the MRI, and then I'll try to identify it with ultrasound. So I'll use the MRI to correlate what I'm seeing with ultrasound. And that's really a good way to become proficient in identifying abnormal anatomy.
And looking at, AMSSM and AIUM, there's a lot of videos that we both helped out with, AIUM on how, like, the protocols on these. There's a reason those protocols are out there, and that we teach our fellows these protocols is so that we're teaching it the same way. Look at these structures. It's kind of like when you look at the heart and lungs, you learn how to, auscultate the same way every time. Like when I do a shoulder scan, I do it the same way every time. And that way I don't miss things. And that's true with any body part, they're all laid out on there.
Same with the procedures. You do it the same way every time you go through your routine. whether it's the needle tenotomy before, the scanning initially, finding where they're point tender, most point tender before you get started. All these things, you'll have a sequence of events in your mind that you do the same way every time, so you don't skip things and make mistakes.
Yeah, the true art of all this, you can train a monkey to guide a needle into anything. The true art of this is knowing the anatomy and being a good diagnostic scanner, even though you make more doing procedures than you do like diagnostic scans, which is interesting to me, because I think the true art of all this is the person that can read an ultrasound and actually knows what he's looking at, or she is looking at anyway. So I think that's kind of the other point I would make.
If you can do an ultrasound guided injection, you can do Tenex.
Yeah.
Okay, very good. Is there actual evidence for rotator cuff tendinosis or gluteal tendinosis? And have you ever used Tenex for posterior tib tendinosis?
Posterior tib tendon goes down with my peroneal tendon comment earlier. The tendon's too small. I think it's a bad idea, personally. Nothing against Tenex, but I think it's a bad idea. I think you're asking for a posterior tib tendon rupture. So the thing you have to ask about the posterior tib tendon is the tendon an intact but incompetent tendon? If you go to move that tendon under ultrasound and it doesn't move at all, you have the bungee cord that's been stretched out too many times. Nothing you're going to do to that with a needle is going to fix that problem, especially if it's a rigid hindfoot. So you have to think logically about it, what you're treating. If it has a high rate of rupture with any type of procedure. I've had it rupture after PRP. I don't inject steroids around it, but I've seen them ruptured after steroids commonly. So it's a tendon, has to do with the stresses on it. I think more going for orthotics, things like that may be a better option. As far as data out there on rotator cuff, we're collecting data now. I didn't present it as part of this presentation because I don't think it's ready yet. We're still just in the early stages of collecting data on that. Gluteal tendon, same thing. We're collecting data on it. I just did 3 gluteal tendons Thursday. It actually is very effective. Now that we have the biggest issue we had with collecting data on this is until they came out with a longer tip, I couldn't get to it in 90% of the people that had the problem. So if they're really skinny, we could treat it. But so numbers are coming up. It works very similar to the hamstring. By the way, if you have people buy a Rojo pillow, those Rojo cushions will evenly distribute the weight no matter how they do it. They can get them on, that's not a promotion to Amazon, but you can get them online for like $100. They fill them up with air and evenly distribute them. I sit on one at myself at my desk just because I have no butt. But after the procedure, you're going to want them to have something to sit on because they're going to be, it's not there, I promise you. I'm going to look like a frog with pants. And this is a comedy portion of her show. Anyway, so get that cushion for after. And these are all in my protocols. If anyone wants to email me, I'm happy to share any of this information with you.
Okay, I have followed Tenex with PRP a week later, and as I am concerned about losing some of the PRP from the incision site. But notice you do the same day. Any tips to prevent loss of PRP through the incision? 2 things.
1, don't go down the same poke hole, right? So I remember this is a learning curve. First time I did this, I was like, oh, just come down the same poke hole. What's the big deal? PRP is sitting on the table. And then I had to be like, well, we're going to redraw your blood. We're going to start this process over. So it's kind of like the rabbit that's been shot in the cartoons. You drink and it just comes, spraying out. So you have to come from a different angle. Advice number 1. Advice number 2, you can combine this with thrombin, like a thrombin clot and a fibrin clot rather, and it'll stay in there a little bit better. So there's a couple ways to get that PRP to stay in there. I haven't had too much issue with it not filling the holes in there, especially if you come from a different angle, the tissues will close up. Plus, remember, the hole you're making with the tenotomy device is small, so it's not like an arthroscopy. So your point is very valid. And when my orthopedic docs refer to me, they say, man, this tissue quality is crap when they fix a rotator cuff. And they say, can you put some platelets or some regen med in here, try to save this from re-rupturing? I do it a week later, after all that swelling's down, after the incisions are healed. But those are much bigger holes than what you're using for this device.
Make sure you aspirate out or squeeze out all that water, because you don't want to dilute it any more than it is.
Very good. Next question. For Achilles, have you tried approaching long axis with the tendon rather than coming from the medial or lateral?
This is a really good question. And this is something that we figured out through trial and error. You could come long axis. A lot of people do. They do it for the patellar tendon as well. it's a very difficult angle to come from. One, because if you have somebody with a big calf, you can't get the device down to lever it to all the areas, because their calf actually blocks your hand from your ability to guide the device. So that's one problem. Two, when we looked at this, we did kind of a mini, did 10 of them longitudinally and 10 of them short axis. And when we came short axis, patients had better results. Also, if it's just the center portion of the tendon, like I was discussing earlier, you can come up through the fat pad. And who cares if you remove some of the fat pad, right? If it's the center of the tendon, you don't want to go through normal tissue if you can avoid it. So I try to stay out of normal tissue if I can and come up from underneath. And I'll do the same thing with the patellar tendon. So that's my 2 cents on it. I think people probably are getting some good results coming longitudinally, but we kind of figured this out coming short axis, with the exception of a few tendons like lateral elbow and this one, which is harder, did better coming from a short axis approach.
I actually do go long axis,
Well, there you go.
and with both the patellar tendon and the Achilles, I just you with the knee, you got to have the knee flexed enough to make the fibers elongated, so you don't create an abnormality when you're looking at it. I'll also have someone, when we're doing an Achilles, I'll have someone commonly just dorsiflexing the foot to improve my angle so that I can see the tip better.
He has a lot of assistants down there at Andrews Institute, so he can have that extra guy holding the foot. I don't have that.
Okay, can you repeat the name of the instrument you use for scraping the Achilles and patellar tendons?
It's a meniscotome. So it's a dual bladed meniscotome. They sell these, they sell hook meniscotomes with a hook. It's an arthroscopy tool. So if you talk to your local arthroscopy rep, they can probably provide you with a myriad of options. I don't quote me on price. I think they're around $75 or something a device. But they, if you are doing these out of a surgery or assisted surgery center, I guarantee you they have them in there for the arthroscopist. You just say, hey, can you add these to my potentially? I might want one of these for these cases. But I use a dual bladed meniscotome, or they do sell one with that's a fork that you can use to cut things with. But the dual blade one is one I use for tendon scraping.
That's certainly the better way to do it. But if you don't have access to
You need
that,
an 18 gauge,
18 gauge needle will do it.
Or you can use the Tenex device itself. Sometimes, although it's sometimes hard to separate the tissue, but you can turn on the cutting, and it's a little bit more tedious going in and out to do that.
Okay, last question. For regenerative therapies, do you prefer lidocaine or another anesthetic like ropivacaine that is potentially less toxic?
Oh, it's a regenerative therapy question, but that's all right. So I know there's one study out there, and probably more than one, but there's one that everyone kind of hangs their hat on, that numbing it before you put in a regenerative medicine affects how the platelets work. I haven't found that to be true. I think the patients are just so miserable if you don't numb it a little bit. So I actually use a little bit of lidocaine, and I'll mix a little bit of ropivacaine in there as well for a little bit long acting. But I agree that trying to put as less canes around tendons as you can is probably better.
If you want to see your patient again, I suggest you use lidocaine.
Yeah, the last referral they give you.
And the patient's not going to come back because they'll tell all their friends, that doctor hurt me.
Yeah.
And so you want to use
Numb
lidocaine. Numb it up.
Numb it up. Yeah.
Okay, first of all, thank you, Dr. Porcho. Thank you, Dr. Hackle, for an amazing presentation. Thank you for your time and for all the great dialogue that we've had this morning. Thank you to the audience who has attended. We appreciate your attendance and jumping onto this on a Saturday morning, so that's great. Don't forget to reach out if you need more information. Contact us at the number indicated there, or email at info@tenexhealth.com. That concludes the session. And again, thank you very much. Have a great weekend.